Professor Massimo is Chair of European Best Information through Regional Outcomes in Diabetes EUBI-ROD Network, President of Hub for International Health Research, Coordinator of Chief Coordination Senior Advisor to IDF Europe Board. Lecture of Professor Massimo. This one. Okay. New insights and challenges of data collection and management in diabetes.
Thank you very much indeed for your presentation, dear chairpersons, ladies and gentlemen. First of all, let me thank Professor Ines Schout for inviting me once again to be here with you in this meeting. So what I'm going to present today is not, I won't present you figures, but mostly concepts, and then to have an overview of the new understandings on how should be the evolution of data collection system. So if we do consider the health and illnesses, they are affected by three main areas of interest, which is the biological characteristics, which are of our main interest, genetic predisposition, or what we know as clinicians. But there are other factors which interfere with health and illnesses. It's the psychological factors and the social conditions. These are, areas which have very little have been explored, but their impact on the quality of life of people and on their health is very much relevant. So what we are usually interested in is the so-called patient-centered care. The patient is at the center of our interest, and we give input from very many areas, and this is from our clinical understanding. But we have to consider that there is the personalized care, so it's not anymore just patient-centered care, but personalized care. We need to receive input also from the people, from the patient, and then they can give information and data, also data for the improvement of the quality of care. So there is the need for an active role of the patient, which is referred to now. We are used to have hard indicators, let's say blood glucose, blood pressure, and so forth. But they come from our evaluation and from our labs. But we have to consider also that the patient themselves, they can produce information. In the past, such information were considered somehow soft. Now they are becoming hard information, and they can be included in a data set. So the patient-reported data, they complement and they do not substitute the physical, physiological, and biochemical data. And the patient-reported outcome is any report of the status of a patient health condition that comes directly from the patient, without interpretation of the patient response by a clinician or anyone else. They are pure information coming from the directly interested people. And the patient, this type of patient-reported outcome need to be measured. So they need to be considered. There is the need for measure through instrument, scale, or single item measure used to assess the pro-information as perceived by the patient, obtained by directly asking the patient to self-report. So there is the need for, which is not easy, because for blood glucose we do have a scale from the lab, but in this case it's much more difficult. We do to have to clearly define methods and instruction for administration responding to the questions. A standard format for data collection. Well-documented methods for scoring, analyze, and interpret the results in the target patient population. So this is it's work in progress, and this is continuously refined in order to be able to include this type of information in a standard set for diabetes, so which contains 3 categories of data, which are patient-reported outcomes, which is the end result of care that are assessed by the patient and reported by the patient, such as well-being and distress. It's not easy to define well-being and distress. We don't have, a scale of figures, and they change with socioeconomic status and according to cultural issues and geographical gradients. So there are the provider-reported outcomes, which are the ones that we are more familiar with, and results of care that are assessed and reported by the healthcare provider. So traditional measures like glycated hemoglobin. And then there are also case mix variables, which variables that affect how well a patient may respond to treatment, but can be changed or very difficult to change as part of the treatment, such as age and smoking status. We can change, but it's not easy. So this produces, there is a cycle, the structured process for defining standard set inclusive of problems. So we do have the provider perspective, our perspective as professionals, the patient's perspective, and altogether with the perspective of to include this information in the registry. So we have a number of items to be considered. We can select the proposed minimum set of outcomes, and we can have the definition of the outcomes, but what is more important, how to measure such outcomes. So there is the data set, and in the data set we can consider the areas of acute events such as diabetic ketoacidosis, hyperglycemic hyperosmotic coma syndrome, and hypoglycemia. We have chronic complications such as treatment of complication, nervous system complication, micro and macrovascular complications, survival also. The healthcare services, the evaluation of the healthcare services, so healthcare utilization, financial barriers for treatment, and diabetes control, the glycemic control. But also we do have patient-reported outcomes, the psychological well-being, diabetes distress, and depression. These are items, indicators that now need to enter into our process for evaluation and for delivery care to the people with diabetes. So, in this, the evolution of information technology create new opportunities and growing complexity. So there is a widening of the catching areas. We are not just, considering people in our own area, but I mean, we need to consider in a much wider area. Increasing number of stakeholders, as I mentioned, the variability of population in terms of socioeconomic conditions, age mix, ethnicity, cultural, etc. The variability of healthcare systems, procedure, and legislation, and then every country, I would say every region has its different, organization for healthcare delivery, and there is a variability of measurement. So this calling for the need of a complex planning, standardization of procedure, and stratification of population. This is, something which relates with with the need to have available more advanced data collection system. We still continue to call them registries, but actually it's a different way, because there is an evolution of the concept of registry, which is from a list of people for epidemiological purposes to real-time backbone for healthcare delivery. We do have the information in real time, and then we can use for delivery of care. Middle-level instrument to timely adjust policies and action to the benefit of specific patients' population, and real-life evidence-based instrument. But we need to consider that there are some caveats. There is the need to evaluate a trade-off between individuals and society benefit and privacy. Then we need to have a few assumptions, which is the registries as a standalone activity have a little value, if any. In the past this was a target, it's just an instrument. The condition for successful implementation of registries is a full integration in the process of healthcare delivery, and long-term maintenance is secured if they improve the quality of healthcare. If there is an advantage, then it's worth to have to invest resources for a registry. If not, it's not worthwhile. So a registry needs to satisfy the needs of different targets for research, epidemiology, administrative purposes, quality of care improvement, and support also to the daily clinical care. So it's quite a wide spectrum of targets, and to the benefit of people affected by diabetes, by disease, policymakers, healthcare decision makers, healthcare administrators, healthcare professionals, research institutions, industries, and the general population. They might have different languages, different needs, so we need to find a way, to provide an instrument which can talk to all of them by adjusting the language to different needs. So just an example of a registry which can somehow fulfill this achievement, which is the Scottish Care Information Diabetes Collaboration, which then can, through the registry, there are collected information from all the possible sources, from labs, from clinics, from hospital, from the primary care, from everywhere. They combine this information on all the different area of interest, the clinical interest, and then they can define the clinical outcomes, but also this can be used and then can receive information directly from the patients. Now we do have the continuous glucose monitoring, which can be through the new modern IT devices. They can aggregate information in real time, and this can be used for education, both on how to use the information technology, and also educate in a wider area for education in a wide scale. So some of the main problems, however, of the realization of the diabetes registry is the source of data collection, the standardization of data from different sources, the regulatory issue, privacy, maintenance, system updating, data processing, timely availability of outcomes, tailoring of information according to various constituencies. So this is, I would say, a new science that needs to be taken into consideration. Of course, there are solutions. I'm not entering into any type of possible, solution for the different issues. But this is just to say that work is in progress for this to be, to satisfy all such needs. This is the scope of a new project, an initiative of the EU Commission, a collaborative health information European framework, which tends to create a condition to realize a European-wide diabetes diabetes registry, but not just for diabetes, but also for non-communicable disease. So the ultimate aim is to design and implement a sustainable information system for the periodic collection of EU harmonized indicators for diabetes. This, of course, diabetes need to be then considered not a standalone condition, but it's part of the wider family of the non-communicable disease. So, and then there is the need also to satisfy the data protection requirement and compatibility with the European health data space infrastructure and regulation addressed from design stage of the information stream. This has been taken care of by a network, the OBIRD, which already managed, EU-based registries. So, and then the design of this project, there are three main areas of interest: data and indicators, federated data analysis, and enabling barriers. Of course, I cannot enter into all this, but I mean just three examples: the metadata, federated data analysis, and patient involvement. Metadata, I mean data that provide information about other data, but not the content of the data itself. And there are a number of questions for elements for an indicator. What is being measured? What is being measured? Why it's measured? How is the indicator out of defined? If we just the example, the blood pressure. We consider blood pressure as just a number, which is in our electronic medical records or in our files. But, it's not, in order to combine this information with different areas, we need to define where, how. It's much more complex, the definition of blood pressure. We need to understand what do we mean by the figure that is reported in our, in our files. So it's a much more complex. So, and all what you see around, the concept of blood pressure is metadata. They describe the concept of blood pressure, but this is the case for any other indicator. So federated data analysis, which is in a data collection system, we need to aggregate information which come from different silos. So we have to combine, information which come from, we have Apple and peers. So there are different silos, different databases. So we need to standardize. And then to transfer this information, standardized information at a higher level in order to have information at local, regional, national, and international level. And in order to prevent, the violation of privacy, this aggregation need to be done at the local level. So what is transferred is information that have already been aggregated at local level. So what is passing through different level is something which has been already digested, and this, of course, is respectful of the privacy and of the cross-border transfer of information. The final point I would like to mention is the patient involvement, which is usually forgotten and not considered, in deep. So not only prompts we have to consider what we talk about, but the full involvement in all the phases of registries development and management. So identification of specific needs. It is the patients who know which are their needs, and that their needs are different in different areas, and this is make things even more complicated. Proposal for best methods for collection of information, which, how to provide this type of information. And what is important important because there are different surveys which demonstrate how the people, the population, are not satisfied by their own, healthcare systems, and this require, surveys which require resources, time, and provide information at a later stage, too late. So there is the need to real-time evaluation of healthcare performances in order to be able to adjust an overall guarantee of satisfaction of heterogeneity of needs. So the needs of the people, they are different according to different gradients. So there is, however, there is a still diffuse archaeological perception of registries, and there is the need of a matrix to define why, who, and how to involve the patient in the process of the set-up and management of a registry. But this, of course, and this, all this has been dealt with the chief initiative, and the data after 2 years of work are going to be made public next week, and I'm not allowed here to, there is an embargo at least now, but then I see, I will show you the results next year if I will be invited to the same meeting, and then I hope today you will enjoy them. So thank you for your attention.
Thank you. Thank you so much, Professor Massini. And that was absolutely brilliant presentation. And it is a very important concept, particularly if you look at the number of healthcare professionals involved in the care of our patients. And I was talking about the model for the cardiovascular renal syndrome that is involving a lot of agents, and everybody is doing bits to the patient, but the patient with the problems is actually giving us the feedback of how well we are looking at them. So it's more patient focused, more holistic, so we understand how the patient is benefiting from what we do. So I really looking forward to seeing your data when you present it in the future. But the key thing is that collaboration of individuals. How do you motivate them to participate in the concept? You need to have, for instance, the same computer systems that talk to each other. Because in Scotland, Scotland is one part of the UK where they've had registries for many years.
Well, 2 points in your question. First of all, a general one which indicates that the non-communicable diseases, chronic non-communicable diseases, they need to be dealt with altogether. I mean, we cannot continue to have different databases for different diseases. That we need to find out a way to have a combined way for this to happen. How to involve the patients? First of all, there is not a single model. There is a matrix. That's why I mentioned why, who, and how, because this needs to be then interpreted in different areas. But if you have a matrix, then it is transparent how you involve the people, in the data collection system. But what is important, that they are involved for what they are expert. They are expert on their own life and their own experience. The big mistake in the past, maybe also in the present, is to involve the people pretending that they become expert in